So this is my client, and this is my client walking. And what I note is that the pelvis appears to be shifted over to the right. Now, that's probably a function of the hip, and it could be a function of the lower extremity. The pelvis has its own set of rules in how it moves with the lumbar spine and with the hips. And you'll notice that the motion of the pelvis is mostly, I'm going to mimic you. It's mostly like up and down this way in the frontal plane. Okay? When your pelvis is over to this side, you can see less space between the arm and the outside of this pelvis. And when you walk, you progress by actually kind of going sideways. Okay, so if you could go again, I think that'll be a little more apparent. So there isn't much rotation in your pelvis in the transverse plane. So there isn't much of this, twisting. I'm exaggerating it, but most of us have some of that twisting motion. You don't have it. And you can also see the shoulders are just so rigid. There's just very, very little movement up in here, okay? So let's bring you back to the table and have you lie on your back. And so I'm going to just do a very quick whole body summary of some of my findings. She has some pain in the back of the right knee. She has some foot pain. And I screened the feet and ankle mobility and told right in, I just couldn't discern anything specific, but I thought that we would find something more when she was on her stomach, and we in fact did. However, I do want to point out that she has a hypermobility syndrome in the extremities, in the feet and ankles. Okay, look at this toe mobility. That's a whole bunch of mobility, especially of the proximal MP joint. And then look at the hyperextension. I can't do this. I couldn't do it if my life depended on it. Okay, but look how flexible these toes are. They just go crazy way back there. And she's got a generous amount of ankle motion. That's easily 15, maybe 20 degrees. But she actually has a pretty decent arch. We should look at that in standing. But if I really push in here, it retains that. But where you really see the hypermobility is in the hand. Now you'll notice her elbow is not, it's not what they call a gunstock deformity, not by very much. And if I try and hyperextend that, it doesn't go any further. But when you come to the digits, look at that. Yes, you can't put this back here as some people can. But nonetheless, you have a whole bunch of motion here. This one makes me laugh. It's so much. I shouldn't laugh at your clients. So I think you can sue me for that. Okay. And here we're just at 90. So it's kind of a mixed thing. The further you go out to the distal joints, that's where you get even more hypermobility. So certainly a job where she had to use her hands and generate forces would not be good. Knees do not hyperextend. Just a little bit. That feels very strong. Core structure does not feel hypermobile. Hips have good range. That's about 90 degrees of straight leg raising, but no more. You see hypermobile people that take it way up. So basically you have hypermobility in the extremities and mostly in the distal and real distal. Okay? But moving on, I want to point out what I find with your knee. I find normal mobility when I load to an end point, the tibia, and then I spring it, okay? And the same thing on this side, and load it, spring, spring, spring it goes, and when I let go there's a final recoil. When I come to her left femur, it appears like the right femur is forward or the left one is backwards a little bit, okay? So when I put my hands here, this one is forward. And because this one's the symptomatic one, I'm assuming this to be forward. When I load the femur here, and I push with about 25 pounds of force to where it stops, and then I thrust it there's a little bit of give, which we believe is primarily in the joint. On this side, I push with 25 pounds of force and nothing happens. I can't take up the slack because it's already taken up. The joint is in this plane of movement. There isn't motion to be had. And so what I'm suggesting is when I push with 25 pounds of force and then I even double it, there's no give, there's no yield. I'm suggesting that this femur is stuck forward slightly on her tibia. And we will treat that later, and we will show the result of treating it. She has some patellar mobility here, left and right. And on this side, much less left and right free patellar mobility. Little bit. Let's see, let's block that. Yeah, you can see that this is quite free if I block the lower leg. This one just struggles because effectively her knee is bent. Okay? So, moving up, her pelvis is very rigid. When I try and move the pelvis in side glide, you'll notice that it slides over a small amount and then it stops moving. And if I push with 30 pounds of force, nothing happens. This is one test where you do have to walk around to the other side of the table. No give. No give. So she's restricted in both directions. Sometimes you'll find people restricted in one direction, especially people who've had chronic knee pain or hip pain or total knee replacement or a total hip. They're still walking sometimes with their hip shifted over, and that can be treated very readily. In this example, you're stuck in both directions. So now I want to focus a little bit more on the pelvic and the sacroiliac and the symphysis pubis joint motion. So I can load here, okay, and if I don't do it properly, I might think I'm at an end point, you know, and I can push with kind of gross force and it looks like it moves. Okay, it's a very precise test. You can't just take up the slack to where there's a soft stop and then try and spring it further, because that gives you a false positive. You really have to slow it down, and I'm pushing in a posterior direction, about a 45-degree angle, and I'm slowing it down. I'm going to take up the slack to the count of 3. 1, 2, 3, and you'll notice that little bit of extra, okay? And now it's at an end point. Now when I try and push, and I'm putting about 15 additional pounds of force, maybe as much as 20, nothing happens. On this side, same thing. When I take it up, take 3 seconds to load it to a distinct endpoint, nothing gives. Okay? This is a 30-year-old female. In this body type, you would predict that she would have normative motion there. And she doesn't. Now, belly button is here. If I come down to the top of the pubic structure and I push on the midline, nothing gives. If I push on the right side, nothing gives. And if I push on the left pubic bone, nothing gives. What I found is that her whole pelvis is locked because the sacrum is stuck backwards. People who have this pattern, they hyperextend in the mid-T-spine. And I'm going to just show you kind of general rib mobility. If I load up a rib to an endpoint, I can still push it further and get some motion. In the midline, we don't want to spring the xiphoid, but right here, mid to lower sternum, there's some give. I can take up the slack to a stop point, spring it, and it recoils. Come up here, same thing, come right here, look. It's absolutely stuck. There is no compliance in this part of her sternum, which is mid-body to upper body. Same thing on the manubrium, no give. But if I come towards the top of the manubrium, you'll notice there's a little bit of give. Okay? Both of her shoulders are rather protracted. You can see the shape of it. this is just very forward. Some people would say the capsule of the shoulder is tight, but that's not really true. It really is more a function of the scapula. And I'm going to push in a 45 posterolateral direction, and I can't even take up the slack in her AC joint. And I can't do that on this side. I can't even pull them down towards her elbow. There's no give, very, very little give. If I come onto the clavicle, it feels like a rock. And if I come on the medial clavicle, that feels like a rock. And if I push the clavicle posteriorly towards the floor, there's no give. She's so locked up here. Now, I want to show you that her shoulder motion is pretty decent. You know, she's not hypermobile in the shoulder, or not by much. This is her internal rotation, and that's her limit. She's about 80 degrees or so. If I come underneath and capture rib number 6, and I'm just going to lift it, I'm going to take it the slack, and then I'm going to spring it, you'll notice the motion traverses through your whole body. Okay, because the rib moves, it allows motion to go through the rib joint and on forward into the rest of the body. And we start to get a little bit tight here. This is probably number 4. When we get to number 3, right here, same amount of force and even more, and nothing is happening. I cannot create motion. And I come up to number 2 here, nothing happens. And first rib here, I might have been off by 1 segment. That's first rib right there. There's no give. So we're seeing a pattern here. And when someone has blocked pelvic mobility, but note that her hip motion is pretty good with respect to rotation. When someone has blocked pelvic mobility, from a posterior sacrum that I will show you shortly, they hyperextend up here. Okay? She has more than that going on because the first rib on both sides is very compressed, second rib is very compressed. So she has more than just the typical hyperextension in the mid-T-spine going on. Folks who present with a posterior sacrum will have very little upper cervical mobility. And if I capture, my force is in front of the pin of the ear, because C1, occiput C1 joint is right here, C1, C2 joint is here, and then the rest of the cervical facet joints are posteriorly. So my direction of force is going to be like this. Regardless of how my hand placement looks, my force is mostly on the temples. I cannot bring her head towards me at all. It's like trying to move a big chunk of granite. There's no motion there. And if I come on top of the mastoid and try and spring it with my thumb posterior, there's no motion on the right, there's no motion on the left. If I come under the mastoid, lift up towards the ear, there's no give, no give. Very shallow sulcus when I come off the mastoid, and that implies hyperextension of the upper cervical spine, which can be a purely muscular pattern. It can involve the joints. And now if I come under the occiput, come right below it, and lift up, these suboccipital muscles are just extremely tight, extremely hard, just remarkably so. Feels like there's an asymmetry up high there, but that's all I can say for right now. We can evaluate that in a little bit more detail later. She does get some TMJ symptoms, but today her jaw's moving pretty symmetrically, and we're going to ignore the jaw for right now. If you could lie on your stomach now, and let's leave your feet off the table, okay? So one thing that I came to realize just by trial and error and paying attention is that a person can have real subtle restrictions in the ankle joint and in the superior fib joint. And because of the shape of the joint, it'll be subtle when they're laying on their back. But when they lay on their stomach, it becomes much less subtle. And that's because you can have a rotation, just given the axis and the shape of the head of the fibula, in which it's much more apparent when the client lays down. And if I position hips and feet fairly symmetrical and stabilize them with my chest here, this fibular head is very posterior. And you may not see that from your perspective, but from my perspective, it's very obvious. And I'm going to try and create a little bit of give here. And you can see that there's a little bit of give with that superior tib-fib joint on the left. On the right, no, I cannot create any motion there. And if I follow the fibula all the way down, the lateral malleoli is posterior also. And if I take up the slack on this side, and of course lots of things are moving, you know, the whole structure is moving, and then we isolate movement in there, and now I can spring it, and there's the slightest amount of spring mobility there. On this side, wow, I can't take up the slack, and I can't create any spring mobility there, okay? It looks like this one might be a little bit inferior, and I'm testing superior glide mobility, a little bit of give on the left. And on this side, I don't feel motion. It's very subtle, but I don't feel the motion. Okay, we're going to keep filming. We're going to ignore that phone. She has symmetrical hip extension. Just relax, and I'm going to just lift your leg up. Okay, so we let the hip follow its own trajectory. It likes to go into a little bit of abduction. And we do the same thing on this side. And that's about 10 to 15 degrees. Now we come to the sacrum. And this is a big player in her presentation. The PSISs of the ilium are right here. So that would make S1 here, S2, S3, S4, S5, and then tailbone. Now here I think you can see, and if you kneel down just briefly, I think you can see that this thumb is much closer to the ceiling. Typically it's the opposite. And I'm proposing that her sacrum is wedged posteriorly. If I take up the slack, oh, I can't even. There's no way that I can take up the slack here. Okay, there's no give. If I try and make the pelvis move superiorly, there's no give. If I try and make it move inferiorly, there's no give. If I try and rotate the pelvis forward, no give. If I push on the ischium, no give. The sacrotuberous ligament comes here at the bottom of the sacrum. It's a broad ligament inserts on the medial part of the ischial tuberosity. If I walk across and find it, it's right here. It feels like a bone. It is so tight that there's no compliance. And we'll treat this and hopefully change it, and then we will demonstrate those changes to you. Now her posture, her body type is one that favors extension. When your sacrum is locked, L5 joint will not move. There's a little bit of give at 4, little bit at 3, on up. I think you can see that force goes through the body. And as we get higher, right here, she stops moving. Okay, but you'll notice that when she gets up in child pose, she has much more mobility. Could you get up in child pose, please? And you can leave your feet off the edge there. And just drop everything forward. So here's her sacrum. Just no give at all. None. Okay, this is the PSISs, so this would be S1 right here, so this would be 5. No give at 5. 4, you can see, starts to move. And you can see that when she's in flexion, her spine has more mobility. And you can get a sense of rib mobility here. Come out laterally. You can take up the slack and spring, and the force goes through that structure. And as we work our way up, you can see it's a mobile thoracic spine. And then we get right here, you can even feel the prominence of that segment. There's no give. No give there. No give there. And again, checking rib mobility. That gives. And that gives. And this gives. Gives right up to that point, and then it stops. You know, I can't even take up the slack in that structure, whereas down here, I can take up the slack. Force goes through that structure and spreads out into the upper extremity. So we demonstrated several motion restrictions that we will treat, and we will film the response to treatment. I know I didn't speak much about the symptoms. I just want to focus on the restrictions throughout her body, and they're quite surprising because for this age, this body type, you would not expect to encounter these kinds of restrictions. And I think we'll stop filming now, and we'll post the part 2 later on. Thank you.